All right, good afternoon, everyone. It's 12 o'clock, so I guess I'll get started. So today I've decided to do a presentation on heart failure in the older patients, primarily focusing on frailty in the context of heart failure and how to make assessments of frailty in order to direct our therapy for older patients. I will be focusing more on larger management strategies rather than medical management itself, because I think as internists and particularly for the cardiologist, we already are quite aware on how to do this. So let's begin. Feel free to interrupt if there's any questions. So the objectives of today's presentation are to talk about frailty and heart failure, and if there is a link, which surprise, there is a link, why it all matters, especially in our hospitalized patients, how we can make assessments of frailty, and what tools are available, in particular in the heart failure population and the cardiovascular population. Some considerations for other factors that we can see in parallel to those patients who are aging and those patients who have heart failure. And then finally, a little bit on management strategies. Okay, so this is a typical case, something that we as internists see all the time, both in the emerge as well as on wards. So Mr. G is an 88-year-old gentleman. He presents with worsening exertional dyspnea, orthopnea, PND, and we're obviously thinking heart failure when we see this. His past medical history is pertinent for ischemic cardiomyopathy with an EF of 45%. His baseline NYH function is 2. He has CKD, cognitive impairment with no previous MOCA or MMSC on file, previous history of falls, but with no fragility fractures, gout, and then below are some of his medications. So when we see a case like this, we tend to focus on how to treat the patient from a symptom perspective as well as a management perspective. And I'm hoping that after my talk, there would be maybe a slight change in our thought process in the way that we see this patient when they come into the hospital. So frailty and heart failure. Heart failure, as you know, is the most common cause for hospitalization in America. Almost 80% of heart failure patients are over the age of 65, with the incidence of heart failure doubling in each decade of life, with an eventual rise to 20% in patients over the age of 80. So something that we see very, very often in the population that we treat here at Scarborough. In addition to a twofold increase in mortality, frailty in heart failure patients experience greater rates of hospitalization. They endure longer lengths of stay and have an increased risk for rehospitalization. Also, from just a purely subjective manner, these patients tend to report lower quality of life scores compared to their peers who don't have an official diagnosis of frailty. Interestingly, frailty appears much more common in patients with preserved EF heart failure rather than those with reduced EF. And the thought process behind that is that actually the prevalence of diastolic dysfunction is more common in the older population and has nothing really to do with frailty on its own. So we know frailty is characterized by low physiological reserves and it's associated with vulnerability to adverse outcomes. And then heart failure is a chronic disease and obviously affects the quality of life of patients. So the question is, are the two related? The answer is yes. When we define frailty, there are many, many different assessments that can be used, but essentially they look at these following domains: unintentional weight loss, self-reported exhaustion, low energy, slow gait speed, and weak grip strength. The weak grip strength directly relates to weakness, which is often what is used when describing this domain. When we're looking at deficits in the frail population, we're looking at mobility strength, balance, motor processing, cognition, nutrition, endurance, and physical activity. And I'll touch a little bit about each of these when we go forward in my talk. Okay, so many of you guys actually might be aware of the 48-5. It's actually well described in the Canadian Frailty Network. And something we learn in residency as well. But basically, the idea is when you see a patient in the emerge, to kind of cognitively make this mental note to assess these 5 domains in patients who tend to be higher risk for frailty. And so we look at cognition, we look at medications, nutrition, elimination, as well as mobility. So for cognition, the idea is to understand their baseline cognition and then identify whether they have delirium. Medications should be reconciled within 48 hours, and then we should make changes that we think are appropriate for the patient. Nutrition, do they have poor intake at baseline and what their intake is within the first 48 hours? Elimination, primarily looking at constipation and retention. And then finally, mobility, which I think is the one that causes the most decline in functional status for patients. As we know, as patients spend longer times in bed, they lose muscle loss. So evidence shows like greater than 5% of muscle loss can be lost per day in bed. So even 3 days in bed results in a significant muscle loss and a result in that functional capability. So we use 48.5 when we're looking at all patients. The question is, can this be used in heart failure patients? I think the answer is yes, but there is no evidence. And so I'm just going to broaden that thought process. So when we're looking at functional status in frail patients, we're looking primarily at physical, cognitive, and social domains. Functional status we describe as we like to terminology, ADLs and IDLs, so basic and instrumental tasks of daily living, basic being simple things like transferring and the ability to feed oneself, while instrumental can be things like making a telephone call or the ability to manage one's finance. In patients who are hospitalized who lose one of these domains that are described, they can have a 40% one-year mortality rate. And these are all patients that are hospitalized. And 17% of patients who are admitted who lose one function will only be the ones that return back to their original baseline. And 30% of patients who lose a function are more likely to be readmitted in 60 days. So losing a functional status in the context of frailty does have significant implications for both hospitalization as well as quality of life for these patients. Okay, so I've already given you a little bit of a teaser, but why does this all matter to us? So heart failure, in particular with our heart failure patients, it's actually known to be one of the comorbidities or one of the chronic conditions that results in the longest stay in hospitals. Patients who are actually greater than 65 years old with heart failure have an increased risk in iatrogenic complications, and these include things like immobility, delirium, and nosocomial infections. Mortality after heart failure diagnosis is approximately 30% in the first year, and it exceeds to 50% in 5 years with other comorbidities. But in hospitalized patients, you can even have a higher mortality of greater than 60% after your first hospitalization for heart failure. I was able to find this statistic off one of the studies that I was reading, that in 2011 in the US, 23% of patients who were hospitalized with heart failure were discharged with home care and 13.3% to long-term care. So I suspect the numbers are even higher now in 2023. And overall, data shows that older patients with frailty and heart failure are at an increased risk for poorer clinical outcomes. Recognizing frailty and a frailty phenotype in patients with heart failure may actually detect those who are going to have poor outcomes during the course of hospitalization and then at discharge. And I think overall, this can help with medication tailoring, outcome predictions, current management strategies that you as a physician take, as well as future planning. So when we're looking at heart failure in older patients, we have to consider factors that are found in parallel with the aging population, as well as those with heart failure. And as we know, these include things like multiple comorbidities. Most patients we see have CKD, AFib, hypertension, et cetera. Those with geriatric syndrome, so cognitive impairment, osteoporosis or fragility fractures, functional decline, problems with mobility and balance. And then the idea of medication tolerance, which can be seen in both patient populations. We know that not only are elderly patients with heart failure at increased risk of developing fragility, but also frail older adults are more likely to develop new onset heart failure. So this diagram kind of reflects the parallel between the two groups of heart failure patients as well as fragility patients who are frail. And as you can see, there are multiple overlapping domains that can be seen in both groups, including cognitive impairment, fatigue, sarcopenia, cachexia, depression, anxiety, poor exercise tolerance, and poor nutritional intake. So how do we assess frailty in patients with heart failure? So unfortunately, there's actually no validated assessment tool, particularly for patients with frailty or those with cardiovascular complications, but we can kind of use other tools that have been implemented for frailty assessments in all age groups and all population groups, versus one specific to heart failure. And most of the studies that you look at frailty in the heart failure or cardiovascular population do use some form of this tool. So the one that you guys must be most familiar with is the Fried's phenotypic definition of frailty and the frailty index. There are like over 20 different scales that are available, but again, they look at 5 specific domains: slowness, weakness, low physical activity, exhaustion, and shrinking. And shrinking is basically the loss of muscle mass, which can be measured as weight loss that is not intentional. And then from objective measures, we use the 5-meter gait speed, which is an objective measurement of slowness, and then hand grip or knee extensor strength, which is a test of weakness. There are also questionnaires that ask patients regarding their exhaustion level, their physical activity level, and their weight loss. The frailty index is one of the most widely used scales and incorporates all these 5 different criteria with the objective studies as well. And a definition of frailty is thought to be one that is when you score 3 points or more. So that's when you're defined as frail. Other assessment tools that you can use are very similar, and they just take into consideration variations in degree of these 5 pretty much domains. So even though there are no proven assessment tools in the heart failure population, there are studies that look at these domains and determine its impact in the frail population. So one of the best ones that have been consistently shown out across various studies is hand grip strength. And it's found to be an independent predictor of survival in the heart failure population, with higher grip strength corresponding with increased survival. In a meta-analysis of over 2,300 patients with CVD, including heart failure, lower hand grip strength was associated with increased risks of CVD death, all-cause mortality, and admissions for heart failure. Additionally, heart failure patients with decreased gait speed or poor lower extremity function at follow-up are at higher risk for readmission for all-cause mortality when compared to patients of the same age group who maintain gait speed or lower extremity function that we see objectively. So there is implications of frailty in overall mortality for these patients when we look at objective measures seen in the index. Next, the question is, as internists, when do we make this assessment? Again, there's not that much data available to us. Excuse me. And unfortunately, the score can change very drastically from when a patient is seen in an outpatient clinical setting to inpatient to when they're discharged. So one of the recommendations by the Canadian Frailty Network, as well as CCS, is that rather than looking at a timing for the frailty score, the importance is to appreciate and note the change in the frailty index over time. So when they are at an outpatient setting like a family doctor's office, to when they're hospitalized, to when they're discharged, and the change is more of a predictor of their overall functional outcome than the actual score that's taken at one point of time. So that's also, I think, something important to remember. So what do the actual guidelines say? The European Society of Cardiology says that the management of older patients with heart failure includes the monitoring of frailty over time, taking into account its reversible causes to prevent increasing frailty, while CCS recommends patients with heart failure should be assessed for multimorbidity, frailty, cognitive impairment, dementia, and depression, all which may affect treatment, adherence to therapy, and follow-up or prognosis. Okay, I'm just going to take a little bit of a sidestep and talk about 2 disease processes that are often co-found in the aging population as well as in patients with heart failure, and are often seen in those admissions that we as internists admit for heart failure patients that are a little bit older. So the first one is osteoporosis. Osteoporosis is a precursor for fragility fractures, as we know. And often we see patients who have heart failure exacerbations who come with a fall, then have a fracture of some sort, or we find incidentally on imaging that they have compression fractures or evidence of osteoporosis on previous bone mineral density scans. And there is quite a bit of evidence to this. One of the first studies that actually showed the link was this one. It's quite an old study. It was done in 2011, and they looked at bone mass, vitamin D deficiency, and hyperparathyroidism and congestive heart failure. Essentially, the takeaway from this study was that osteoporosis and osteopenia were more prevalent in the heart failure population, with higher incidences of low bone mass and vitamin D deficiency. And then this study, which actually looked at orthopedic fracture patients, showed that in over 16,000 plus patients, that heart failure had a 4 times risk of a fracture in those patients, as well as a 6 times risk in hip fractures than their cohorts that didn't have heart failure. So is there an actual objective link between the two processes, or it's just passive because they're both aging? They were both seen in the aging population. There are some thought processes behind the physiology of this, and that's outlined here. Obviously, they both share similar risk factors: aging, low bone density, low exercise capacity, and tolerance. But there also may be a link in the fact that patients with heart failure tend to have elevated aldosterone levels, and those are also commonly seen in the OP patients and the fracture patients. So that's something that I think we should also recognize when we're managing these patients, more in probably the outpatient clinical setting, because you can actually make a difference in OP management versus in the inpatient setting, where it's difficult to risk stratify these patients. The second thing, which I think is far more relevant to us as an inpatient service, is cognitive impairment in the heart failure population. Heart failure management, as we know, is very multidisciplinary and involves quite a bit of adherence from the patient himself or herself. And so things that are kind of impeded because of cognitive impairment include adherence, diet recommendations, activity recommendation, and then most importantly, symptom monitoring. And in older patients who have heart failure, they have a 60% increased risk of cognitive impairment compared with their age-matched peers. Cognitive impairment, as you know, is also commonly cited on many frailty assessment scales and is more prevalent in the heart failure population and has been associated with increased risks for hospitalization in those patients compared to heart failure patients who don't have a history of cognitive impairment. So the mechanism behind it, there's obviously many thought processes behind this, but some of the 3 more commonly seen presentations are: there is an increased risk of thromboembolic strokes in the setting of heart failure, which can result in vascular cognitive impairment. You can see hypoperfusion from poor cardiac output and increased cerebral vascular reactivity. And then heart failure medications on their own have their complication that can result in acute changes in one's cognition or long-term cognitive impairment. So what is the research that's actually available in the older population? Again, there's a posse of research that's available, and there's underrepresentation in the elderly population. Actually, if you look at a lot of the RCTs and the landmark trials that we use to guide therapy, most of them tend to enroll on the younger patient spectrum than the older patient spectrum. And in particular, some of the newer studies like the SGLT2 inhibitors and the ARNIs tend to have a lower mean age population. But there is quite a bit of evidence that was taken as post hoc analysis from some of these landmark studies. So in the context of dapagliflozin, they actually showed a reduced risk of worsening heart failure or cardiovascular death, regardless of your frailty index class. And interestingly, there's consistent benefits that were observed for other clinical events and health status, but the absolute reduction was actually more in frail patients than in their age-matched population who didn't have a 3+ frailty index score. So that actually makes us think that sometimes when we're a little bit hesitant to start SGLT2 inhibitors in the older population because of their frailty index, that maybe we should consider starting them as long as there's no other comorbidities that prevent them from getting the medication, because regardless of their frailty index, they actually ended up doing quite well from a cardiovascular outcomes perspective. A similar post hoc analysis was done of Paragon HF, which used the Rockwood Frailty Index and looked at Entresto, as we know, in Paragon HF, and compared with Entresto and the placebo arm, it seemed to show a greater reduction in the primary endpoint with increased frailty. So again, a higher benefit in the frail population. If you look at some of the other kind of landmark trials in iPreserve, the irbesartan trial, the mean age was actually 76. So it's a good representation of the older population. But if you look at purely trials that enrolled older patients and studied older patients in the context of medical management, then there's actually only 3 really important trials that are available. And the one most commonly known is the seniors trial. So the seniors trial is actually the only trial that enrolled patients over the age of 70 when looking at beta blockers. Its mean age was 76. And they showed a significant reduction in the combined risk of death or cardiovascular rehospitalization, but no significant effect in overall survival in patients who received the beta blocker versus the placebo arm. The EHFS2 trial, which is basically the European heart failure survey trial in hospitalized patients, it was a very large cohort, like a very large study that was done across multiple sites in Europe. And it was a more subjective style study, but essentially the takeaway point from that was that both underuse as well as underdosage of medications were observed in the elderly population when it came to heart failure titration of meds. And then the most recent study that's available to us is DELIVER, which actually does look at dapagliflozin in the elderly population. And it showed that frailty was common and associated with worse outcomes in heart failure patients, which we actually already knew based on my previous slides. But the benefit of dapagliflozin was consistent across the range of frailty studied. And the improvement of health-related quality of life with dapagliflozin occurred early and was in greater numbers in patients who had higher frailty levels. So again, another evidence that medication can sometimes actually be more beneficial in these patients with higher frailty index. All right, so the last few slides will kind of focus more on management strategies in these frail populations. So CCS recommends heart failure therapies in frail or older patients should be similar to those in younger patients. Heart failure medications may be introduced according to them at lower doses and titrated more slowly, but we have multiple kind of evidences in my previous slides, as well as in analysis of other landmark studies, that medications actually do improve other factors other than just plainly symptom management in heart failure. So ACE inhibitors preserve cognitive and physical function in according to CCS and their recommendations in the frail population. And in heart failure patients with preserved EF, RAS inhibitors prevent hospitalization and improve quality of life and exercise capacity. This is data from 2017, but I think it's still quite applicable to the patients that we manage who we do often put on ACE inhibitors. Other things that we should consider when we're looking at pharmacological therapy is that we know as you age, you lose body mass and total body water. And we also know that pharmacologically, there are impairments to our metabolism pathways, especially like first pass metabolism from the liver pathway. And so when we're actually starting medications, we should consider these factors when we're trying to titrate doses. And I think that's also reflected in the guidelines where they tell you to start low and titrate more slowly. One of the 2 things that often get missed, especially in the frail population, is the importance of exercise as well as nutrition. So evidence does show optimization of symptom control can improve overall exercise tolerance, and that in itself may reduce the frequency of heart failure exacerbations and hospitalization and improve overall quality of life. And from a nutrition perspective, we often implement salt restrictions and fluid restrictions, even in our older population. And as we know, this can be harder to implement for the elderly population. And in general, evidence shows that the elderly population have a tendency to drink more fluids. And it's also difficult to adhere to because of cognitive impairment. So something to consider when we're titrating therapy and discussions to have around overall nutrition. And then salt restriction, the NHN ACE3 study that we often quote when we're trying to determine, when we say 2 grams of salt per day, actually showed that in patients with a median age of 70 or older, that in women, their average intake of salt was 2.3 grams, and then in males was 3.1 grams per day in men. So also something to consider when we implement salt restrictions in these patients. I think the other point that's important is trying to get the caregiver involved in these restrictions, especially in patients with cognitive impairment, which we actually already know and implement often when we're practicing in hospital. And that takes me to the next point, the importance of compliance and symptom management. So in heart failure, there is really good, data that daily weights and measurement of symptoms can help guide therapy and prevent rehospitalization with titration of medication at home. So engagement of the caregiver, engagement of the patient through education tools, or even referral to the heart failure function clinic can help with this aspect of care. And then there is actually data that shows that there's a tendency for older patients not to be referred to a cardiologist during the hospitalization of acute heart failure. So that is also something we can consider to see if that would have a beneficial impact and long-term follow-up for these patients. I think we're lucky here because we have the heart function clinic, so we have the ability to do that if necessary. I think the overall take-home point, though, is that all the care that we do, as we all know, should be patient-centered care, and it overall is associated with better quality of life, lower symptom burden, greater engagement in self-care, preservation of overall function, and lower admission rates, as well as hospital stays are shorter. So if we go back to our case, it's Mr. G. He's an 88-year-old gentleman who presents with heart failure. And previously, we would look kind of at his past medical history, his medications, and figure out a overall management plan. But I guess the purpose of my presentation is to urge you to look at it with a slightly different lens, which I think we do, and probably inadvertently when we look at patients who are older, but to maybe focus on some of the domains of frailty, including slowness, weakness, low physical activity, exhaustion, and weight loss, and kind of observe a baseline when the patient is admitted from their caregiver or from the patient themselves, and then monitor the functional decline and see if there's any way we can make interventions to increase their ability to preserve these domains before discharge. And then when we're looking at management, apart from just medical management, when it comes to pharmacological therapy, we can consider thoughts like, are we setting up a good follow-up plan for these patients? Are we providing good education to parents, patients, and caregivers? Are we titrating meds accordingly? Are we being a little bit more adverse because of their age? And maybe we should consider actually giving them the medications that may be appropriate at the time of discharge rather than waiting for follow-up. Are we considering exercise and nutrition in their overall treatment plan? And overall, what are we trying to restore? What are we trying to do during hospitalization to restore function that is lost during their stay in the hospital? All right, so I'll just conclude with some takeaway points, which I think I've emphasized on hopefully the previous slides. One, we should consider frailty when we're looking at patients with heart failure and all older patients for that matter. Two, we should not necessarily limit medication management based on frailty alone. Three, we should consider other aspects of care, which include exercise and nutrition. And then overall, we should look at a patient-centered care using a multidisciplinary team approach, which includes early consideration for long-term planning, early consideration for referrals to specialists, including, palliative care or cardiology specialists. And that's it. So does anybody have any questions? All right. Well, thank you very much.